We're going to ask you to just hold questions to the end. We'll have a panel Q&A, so I'll go through all the speakers and then everyone can come up with their questions. But thank you, Steve, for that interesting overview of the photon technologies. Our next speaker is Dr. Anthony Zietman. Dr. Zietman is from the Massachusetts General Hospital in Boston, radiation oncologist focusing on GU cancers. He is the Shipley Professor of Radiation Oncology at Harvard Medical School and the editor-in-chief of the International Journal of Radiation Oncology, Biology, and Physics.
Thank you, Carol. Thank you, Ralph, for the invitation. My charge today is to give you the science behind proton beam therapy. I'll just emphasize what Steve Shimura has told you. There are certain principles that underline radiotherapy that really feed into our thinking. Radiation-related complications do not occur in unirradiated tissues. That's a core principle. And that normal tissue irradiation, even if it doesn't cause a complication, cannot benefit a patient, to be minimized. And one can optimize the therapeutic ratio by maximizing the radiation dose to the tumor in order to increase cure rates and minimizing normal tissue dose to minimize complication rates. That's it. That's the principle of radiotherapy. And our history, as Stephen went through, is based on many principles. It's not enough to just have a radiation beam. You've got to understand how to use it. You've got to understand radiation biology. This is the reason why we give radiation in multiple small fractions rather than as a great big single blast. The improvements in imaging have been incredibly important, as was described, for visualizing the tumors and targeting the radiation. And the improvements in computing power have just made technological sophistication possible. But the fourth pillar of our specialty, of the advancements in our specialty, are improvements in what we call the delivery systems. You've seen an image like this. You know, this is the last 115 years of radiotherapy, starting with the application of radium needles or radon seeds to a skin cancer, moving up to early external beam treatments, the treatment with higher energy beams to treat deeper tumors, to the linear accelerator where we are today. So we believe that there is a kind of arrow of progress, where if you plot technological sophistication along the x-axis and clinical gains on the y-axis, it sort of projects upwards. And one could argue, Stephen has taken you through orthovoltage 3D radiation, IMRT, SBRT, and you could argue that proton beam is actually at the head, at the tip of the arrow. So let's learn a little bit about protons. But first, we have to contrast them with traditional X-rays or photons. Traditional photons, as you saw, pass into the human body, and they're attenuated as they pass through. They continue to deposit their dose beyond the target, which is the tumor. A proton beam is a kind of particulate radiation, and particles can be accelerated and literally thrown into the center of the human body. They deposit very little radiation while they're traveling fast. But then as they slow down at the end of their range, they dump off all their radiation in what's called a sharp Bragg peak. So if you look at the radiation deposition in tissue, this is for a regular X-ray, a photon beam. You've got the skin on the left. This is the depth in tissue. The tumor is somewhere deep. There's a little bit of buildup initially, but you can see a lot more radiation is deposited before the tumor than in the tumor, and then less beyond it. So there's a tail beyond in addition. These are protons. The beam can be accelerated into the body. Very little radiation is deposited until the protons start to slow down, and then all the radiation is dumped off in a sharp Bragg peak. And therein lies the potential advantage of protons. Looked at a different way, this is a photon beam entering a patient. The tumor is in the center of the body. You can see the beam fading out as it passes right through. We get around this problem, of course, if we were going to try and treat a tumor to dose X. you'd have to treat the more superficial tissues to twice that dose if we treated with single beams, with photons. We don't. What we do is we summate beams. We have multiple beams coming from multiple directions. And we do this with very increasing levels of sophistication up to what you've seen in the last presentation. With protons, however, you can send a beam directly in, very little radiation in advance, nothing beyond. You can use a few extra beams if you want to improve the dose distribution over the tumor, like so. So compared with the photon beam arrangement, proton beams, at least on paper, tend to look much better. Their dose distributions look much more favorable. And there's nothing new about proton radiation therapy. This is an incremental advance. This is not a disruptive technology. This is just the latest step. Cyclotrons that accelerate protons have been around for an incredibly long time. They were first proposed shortly after the Second World War for use in the treatment of cancer. The first patient was treated in the 1950s, and in Europe in the late 50s. Harvard got adapted its cyclotron for use on patients in the 1960s. And by the 70s, patients at Harvard, my institution, were being regularly treated. Certain selected conditions, eye, skull base, and prostate. FDA approval, FDA approval for protons came in the 80s. The first patient-dedicated facility opened in 1990 at Loma Linda, and that takes up to the present day where we now have 42 operating centers worldwide. So how are clinical proton beams generated? The cyclotron accelerates the particles. They're shot out along the beam line, bent by magnets, turned up through this large thing called a gantry, and you'll see the patient's little black speck lying down on a couch on the far right. So you get a sense of the size of these devices. They are absolutely enormous. And if you're going to have if you're going to invest in a cyclotron and you've got one beam line, you might as well branch it and treat multiple patients simultaneously. So often these facilities come with multiple gantries. The reason we're discussing protons today is not because it's, as I said, it's not because it's a disruptive technology, or it's simply because of the cost. The installation costs are extraordinary, and they exceed the installation costs of almost any other medical device that we use in 2015. And depending upon whether you have one gantry or 4 gantries, the cost is anything from 30 million to 180 million. And that is really what makes the difference. There are many bells and whistles to proton therapy that I will not talk about today, but they add accuracy to the treatment, they add cost to the treatment. In the United States, for many years, there were just 2 centers, Harvard and Loma Linda, and life was simple. There are now many more centers, and this is going to resemble the robot map that Tina showed us earlier. We're not up to 2,200 proton centers, but boy, we're rising exponentially. There are many more in the planning stages, at least 20. It is not clear whether this is sustainable or not. It is not clear whether this is a bubble that will burst, whether all of these centers will open. Much of this is going to depend upon national and payer policy. So what are the clinical advantages of proton beam? Well, because less radiation is given to the normal tissues, because there is an absent exit dose, there should be improvements in the acute tolerance of radiation, allowing the delivery of higher radiation doses, allowing integration with chemotherapy, better cure rates, and a reduction in the dreaded late effects of radiation. Now, the very best indication for proton beam, most of us agree, is in pediatric cancer. Children are uniquely sensitive to radiation. There are profound effects on their growth and their development, intellectual, endocrine, physical growth, as a result of radiation therapy in childhood, really distressing consequences. And they are very predictable. Children also have a phenomenally high risk of radiation-induced cancer. If you treat a child with Ewing's sarcoma, with radiation, and we do all the time, very likely to be cured, but they have something like a 20% risk of a subsequent cancer induced by the radiation in their lifetime, and that cancer will likely be fatal. So anything we can do to reduce the amount of radiation delivered to the normal tissues of children is a good thing. And many of you have seen these pictures before. These are some classic pictures. It's a child with medulloblastoma. You have to treat the brain and the spine. If you use photons, the beam exits through the developing heart, lung, and gut. If you use protons, it doesn't. Treating orbital tumors of children, you can either have beams exiting across the developing brain with all the intellectual consequences, or if you use protons, you just don't have to have that. So traditional comparative effectiveness research does not exist in pediatrics. And it doesn't exist because there is no equipoise. There are no randomized trials because no one is comfortable entering patients into randomized trials. I'm a profound believer in randomized trials, but I wouldn't be putting my kids into a randomized trial of protons versus conventional radiation if they had a childhood cancer. And there's pretty much unanimity amongst the radiation oncology community globally that this is an appropriate indication for proton beam. Just because there isn't, classic comparative effectiveness research, there are comparative treatment planning studies and in silico modeling of second tumor risk. And it has been calculated that the number of second tumors in treating children can be cut by at least 50%, depending upon the clinical scenario, maybe even much more than that. And even a system that is non-market based, that is, one could say even more thoughtful in its approach and application of new technology, is convinced that proton beam is necessary. So a big commission in Britain looked at the need for protons. They were sending all their patients to Florida and to Boston, their pediatric patients. They've decided they need 2 facilities in Britain, 1 per 30 million of the population. One will be in Manchester, one will be in London. They're opening in 2017. So even the British agree, without randomized data, that there is a strong indication here. Now, what about adults? There are some accepted adult indications for protons. These are skull-based tumors, eye tumors, spinal and sacral tumors. And here it's not that the evidence is strong. It's just that the alternative treatments are so unacceptable. You can't be operating around the skull base. You can't be delivering very high radiation doses to these complex-shaped tumors at the skull base or often in the spine. So it's almost the only way to treat with high doses skull-based tumors. With certain eye tumors, like, for example, melanoma, there aren't really many, the alternative is exenteration or radiation with blindness. So these are unacceptable alternatives. So, as I said, it's not that the evidence is strong, and there have been no randomized trials, just that the alternatives are unattractive. For the more common, but as you all know, you can't sustain your big 4-gantry proton facility on these pediatric cancers or these rare tumors. You simply won't have the patients to amortize your debt. So many have been looking at the more common cancers and asking, do the physical advantages translate into a measurable clinical benefit? And you could look at cancer control, quality of life, or second malignancies. Now, as Dr. Evstathiou is going to talk about tomorrow, there are big problems with doing randomized trials to test proton therapy. Some have ethical objections. I personally don't. The advantages may well be small, meaning that the trials have to be large. The advantages will come late, meaning that the trials will have to be long. And by then, who knows, the technology may be outdated. And there is a huge initial investment for protons that has to be recouped by the institutions. And that actually stands in the way of this kind of research that we need to do. And a calculation done by one of our statisticians looking at trying to reduce the incidence of second cancers, a very noble endpoint. There's not a high risk of them in adults, but there is a risk, a real risk. And you need trials with thousands of patients comparing photons with protons if you're going to demonstrate a benefit. Others have used large databases to try and see whether the second malignancy risk can be reduced. This is Chung, published last year. It seems like it can, but these databases have all sorts of flaws in them. And this is a much contested study. And I cannot talk about protons in adults without talking about prostate cancer. I have to talk about prostate cancer because the majority of patients, the majority of adults with cancer in the United States treated by protons have prostate cancer. And there's a reason for that. As the proton centers were ramping up, that was coincident in time with PSA and this huge increase in the number of men with low-risk prostate cancer. The surgical options and the old radiation options had a bad reputation. Men began to seek what appeared to be a very attractive alternative, and there was this huge uptake in men seeking proton beam radiation for their prostate cancer treatment ahead of the evidence. So we've spent a lot of time thinking about this. We've not done comparative effectiveness research. We've used protons to try and escalate radiation dose. Proton beam is not sham treatment. It's radiation. It's the real thing. You cure many men with prostate cancer, but is it more than other forms of radiation? We did a case-matched analysis comparing protons with brachytherapy or seed implant. Didn't seem to increase the cure rate. Others have used the SEER database, Medicare claims data, to see whether protons cures more patients or causes more or fewer complications than other kinds of radiation. Doesn't seem to cure more patients, but then we wouldn't really necessarily expect it to unless it's used to escalate the dose. There have been a number of single institution or multi-institution prospective studies looking at quality of life, but again, without a comparative arm. We can see that men treated with prostate cancer treated with protons seem to do pretty well. So it's real treatment, it's low morbidity treatment, but is it better treatment? We don't know. Our group have, with the health others, have looked at 3 different prospective studies of 3D radiation, IMRT, and proton beam, and there is a hint in terms of quality of life. There's some reduction in early toxicity, which is intriguing. Another contemporaneous cohort study, and I won't go into the details of this, seemed to find no difference between photons and protons in terms of urinary, bowel, or sexual issues. And another one of the SEER database studies seemed to suggest that there was a higher instance of rectal complications with protons. So you'll hear more about this tomorrow. This is a perfect situation for a randomized trial. The new treatment could be better, it could be worse, or it could be just the same. There are many new opportunities in which protons may be used in adults, perhaps with more beneficial effect than prostate, left-sided breast cancer to reduce the incidence of cardiac complications, pancreatic cancer. Anything we can do that's beneficial in pancreatic cancer will be good. Retroperitoneal sarcomas, where your radiation dose is limited by the gut nearby. Paranasal sinus tumors, where the radiation dose, these are curable cancers, but the dose is limited by the temporal lobes next door, lung and liver cancers. So there are clinical trials going on at the moment, IMRT versus protons in lung cancer. A whole new opportunity is emerging in the world of hepatocellular cancer, where protons can be used to very sharply treat in situations where we previously could not treat at all. And so to conclude, I will say that in 2015, we know that proton therapy is accurate and it's effective. That we know, that's not in dispute. It rides the sort of minimally invasive wave, so that feels good. There are many technical and biological advances that are being progressively brought into proton beam therapy. So it's not like it's fixed in time, it's improving over time. And there are new centers being established globally. So there's widespread belief that we have to have proton therapy somewhere, somehow. I would say that it is the treatment of choice for pediatric solid tumors, even the British agree, and for selected adult tumors. But the relative benefit versus photons, and particularly the new variants of photon therapy in adult patients, are unknown and need to be studied in some cases in randomized controls trials, in other cases using alternative forms of evidence, perhaps registries. And I want everyone to know that as well as technical advances and biological advances, actually cost reduction and efficiency is a research priority. And many people are looking at miniaturizing proton facilities. Anything that can decrease the size and cut the cost will reduce this as a debate. And I just want to finally say that there is an economic development trap that it's really incumbent upon this group to find a way out of. If an institution invests $150 million in a proton facility, it's tough to then ask it to do research with no reimbursement. I've talked a lot about this around the world. And actually in France, I gave a talk on protons in French, and I had to learn the word for a trap in French. So if I teach you nothing else today, I'm going to teach the word une piège. It's a trap. And the reimbursement system and the way protons have rolled out in this country has been a trap from which we need to extricate ourselves. And I hope that the wisdom of this group is going to find a path. Thank you.